Hello, hello. It's an early morning session, and we are having Dr. Shashank, Dr. Shubroto, and Dr. Hazim. Thank you very much for coming. Our session, we have to start even if there is nobody to listen. First presentation is by myself, management of rock-hard cataracts. Next is phaco in small people. We have Dr. Suven Bhattacharjee with us. Dr. Suven Bhattacharjee, everybody knows. He is the, inventor of BHEX pupil expansion device and BHEX forceps. And small people phaco has been made simple, and we are very confident in doing small people phacos nowadays because of his invention, the BHEX. He was with me in Jipmar, Pondicherry, and I was doing diploma in ophthalmology and he was doing MS, but I was 6 months senior to him, and I'm happy to inform you that I taught him DCT. Okay. Then I have a case of 3 to 4 clock hours of zonular dehiscence, how I managed that case. Then we have Dr. Sugato Paul. Dr. Sugato Paul was he was member scientific committee of OSWB, and he's a very senior surgeon, and he's an excellent teacher. We will learn from him the management of posterior polar cataracts. And then what I designed recently is a pre-chopper to divide the soft nuclei before we go into the anterior chamber with the handpiece. Pre-chopper and sustainer, I have a presentation in that. So with these few words, let me start. It's not coming in the screen. Okay. So to overcome any challenge, we have to be stronger than the challenge. We have to groom ourselves. We have to exercise and be stronger. We have to be more experienced. In rock-hard cataracts, manual small incision cataract surgery is a good option if the surgeon is not competent enough to do phacoemulsification in such cases. It's a very good option. This is a video from Arvind Eye Hospital, Pondicherry. So you'll see, I'll have to just forward this. How can I? Suben, please come in. Forward korar barta pachi na keno? So we have to make a large sclerocorneal tunnel, and then we can safely deliver after a large rhexis. We can safely remove the nucleus, deliver the nucleus through this large wound using whatever technique, either fish hook or irrigating vectis or viscoexpression, whatever. But we should do a very safe surgery in hard cataracts, and so that the corneal endothelium is not damaged. Okay. Next is, this is Mohanta's modified SICS. Here, we make two small incisions side by side, and this wound becomes large, but at the end of the surgery, we will have to put just one suture at the apex of these two wounds. So just SICS, but the wound is like this, two SICS wounds side by side. I sometimes call it double SICS, or in this case, the iris came out and immediately the pupil became small, but still we could manage it. A rigid IOL is placed, and at the end we just put on suture. There is no sagging of the wound, and the astigmatism is taken care of. And now let me tell you about Mohanta's submarine chop. This is meant for cataracts which are hard, which are grade 4 or grade 5. In such cases, we stain the capsule with trypan blue dye and do a large capsular excess. Management becomes easy, and nucleus management becomes comfortable if we do a large excess. Hydrodissection is done at multiple points, and small amounts of fluid is injected at multiple points. 3 ways to divide such things: divide and conquer technique, direct chop, that is my technique, submarine chop, and crater and chop. Submarine chop is where you don't make any trench. I go with high vacuum and high flow and high power, 70 to 80, 90%, 75 to 90% power, and in continuous mode. But when we bury the tip into the substance of the nucleus, we have to control the power so that the initial engagement, initial embedding into the substance of the nucleus, at that time we deliver very low power so that cavitation bubble doesn't form. After going inside the nucleus, we can apply higher power. This is in this video we are going to observe. This is a video highly edited, and it is about 4 minutes. So this is the almost black cataract, grade 5 nucleus. We may think, is it possible to do such cases without making any trench? Yes, with this technique it is possible. A large capsular excess is done. After making the large rhexis, hydrodissection is done at multiple points, and at this time, small aliquots of BSS or ringer lactate, whatever you are using, is injected. The nucleus is mobilized. Visco is HPMC. We can use viscoat, and underneath the viscoat, we can use HPMC. And now, some superficial cortical lens matter is removed, and then we have to go and travel through the substance of this nucleus. As a submarine moves through water, here the tip of the phaconeedle will go through the substance of this very hard nucleus. No sculpting is done. The tip is buried just in front of the main wound. It goes through the substance of the nucleus near the opposite equator, and as it reaches near the equator, the chopper is used to get a nice crack. Now 1 or 2 sculpts to go to deeper plane. Hold the right heminucleus with vacuum, and the chopper divides the two heminuclei completely. And this heminucleus is being divided into 3 pieces. This is one piece. When we divide the heminucleus, similar technique, the phaconeedle goes through the substance of the nucleus and we divide it. And now we tilt each nuclear fragment and emulsify. You can see there is no cavitation bubble formed because we have to control the power by our foot. We have to train the delicate foot muscles so that we deliver appropriate amount of ultrasonic energy at the right time. At this time, since I am using only HPMC, I come out, fill up the anterior chamber with visco, and then again I go with the handpiece. And now this heminucleus is divided into 2 pieces and emulsification is carried on. See, some cavitation bubble formed. Immediately we have to use aspiration and remove those air bubbles. At this time, if we tilt the handpiece and the irrigating ports are directed towards the bubbles gets move and come to the aspiration port. And now, during emulsification of the last 2 nuclear pieces, we have to be extra cautious. At this time, if we lose patience, anything can happen. We can just touch the posterior capsule and all our efforts till now may be lost. So we have to be very careful at this time. If necessary, at this time we come out, inject visco, place the lens under the piece, and over the IOL scaffold, we can remove the last piece. So this is submarine chop, and it may not happen in all cases. When submarine chop fails, we have to make a deep crater at the center, and from there, we have to start chopping. The nucleus is huge, and the phaconeedle. In this case, let us forward this to capsular axis is done. And now this is a harder nucleus. And the tip is not going to the proper depth. And as I go near the opposite equator and try to chop this, the chopper just scratches the surface and it cannot crack the nucleus. So I go to scalp mode, make a deep crater at the center so that the tip can be nicely buried into the substance of the nucleus, go to proper depth, and then start chopping. This is crater and chop. And after making several cracks, we start emulsifying the nuclear pieces. Sometimes the leathery posterior bands are there, so it becomes very difficult to separate the pieces. We have to get on free piece and then continue. And once we finish such cases, we become more confident about managing next cases. Thank you very much. And now I invite my friend Dr. Suven Bhattacharjee to enlighten us on small pupil phaco.
Good morning. Thank you, Dr. Mohanta, for this opportunity. a wonderful course, and we look forward to having these presentations every year hereafter. Now, I'll be talking on phaco in a small pupil. Okay, so phaco in small people and IFIS can't be very far behind, so it's all about anticipation, identification, and management. I'm Suvin Bhattacharjee, and I do have a financial interest in the BHEX pupil expander. Now, why is small pupil such a big problem? When the pupil size comes down to 4 millimeters instead of 8 millimeters, the surgeon's viewing area is reduced to a quarter, and that's a significant reduction. So again, there is the issue of IFIS, which is intraoperative miosis and iris prolapse, which is absolutely unpredictable. And let's just see if iris hooks can prevent it. Now, this is a presentation which I did in 2013 in the ASCRS, and it was sent around all over the world. So this is a case of severe IFIS. I already have iris hooks in place, and yet you look at the iris, it's prolapsing from every port, and it's absolutely frayed even before I've finished my capsular excis. This was a disaster. So hereafter, every time my phaco probe entered, the iris was sticking to it. And you can see that knuckle of iris over there. We did get away with this case, and we put a lens in the bag. Nevertheless, what I wanted to show was that iris hooks really do not prevent. So do pupil expanders or rings prevent? No, that also does not. So you can see the iris prolapse to the side port, and in a moment you will also see the iris prolapse to the main incision. So it's not about IFIS has three components, of which we are concerned about miosis and iris prolapse. As far as the miosis is concerned, iris hooks and pupil expanders provide a constant pupil size, which offers good visibility for safe phacoemulsification. As far as the iris prolapse is concerned, no device can help. It depends on the IFIS severity and the pathological damage to the iris. So if you do not have iris prolapse on a given day, it's just that it was milder version of IFIS, and no credit to the device as such. One question I always ask, I request you, ask yourself, if you are the patient and going under the scalpel, what would you like? The surgeon to show his bravado and skills and not use a device, or be safe and use a device? So keep that consideration in your mind when you're dealing with your patient as well. Now, this is the long list of predisposing conditions which can cause IFIS. So no amount of history taking can really prevent surprises, and it's an absolutely unpredictable situation. So can we see the pre-op pupil in the OPD and come to a decision as to whether we'll have IFIS or not? Unfortunately, no. For a pupil 7 millimeter or smaller, the risk of IFIS existed, okay, regardless of alpha blockers. Now, the risk of IFIS is much higher in India. It's a wonderful paper, it's a landmark paper, and hypertension is often a cause of IFIS as well. So surgeons fortunately have lowered the threshold for using a pupil device because IFIS is unpredictable, because patients' expectations have become more exacting, and of course the unforgiving nature of premium IOLs. So this Chang and Campbell told us in 2005 that unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So which brings us to the conclusion that mechanical dilatation of the pupil does not help in IFIS. It does help in the rigid pupil. So we must keep that in mind. Now, so the pupil is only of two types. One, the small pupil. One is elastic and the other is non-elastic. The elastic pupil is much like a rubber band. It's stretchable, so any device will work. Whereas the rigid pupil is like a string. It's tearable or breakable. So you need either a bulky device or two Coughlin hooks to stretch it before you start doing the surgery. So you have to be watchful of that. Now, before starting, we could check the elasticity of the pupil. Just inject BSS through the side port and inflate the AC. If the pupil expands momentarily, you know that we are dealing with an elastic pupil. And if it does not, like in this next case, you may inject as much as BSS you want. This pupil does not budge, so you know it's a rigid pupil. It's a good idea to use two Coughlin hooks and produce a controlled, pupil expansion. Now, once you have done that, you have a situation which is now renders this pupil into a kind of elastic pupil. So what matters most is the elasticity of the pupil and not the size. So how big do you want the pupil to be for a safe phacoemulsification? Now, if we ask ourselves, if we are assured that the pupil will not come down less than 5.5 millimeter, I guess all of us can do a surgery. So, I'll be on. So, BHEX gives you a 5.5 millimeter pupil, and even if you're using iris hooks, I would strongly recommend that you do not move more than 5.5. So this is a wonderful video by Dr. Deepak Magur. It's a rigid pupil pseudofixation. There's a little bit of stretch done, and now that pupil is a little elastic. Now you can tuck those flanges of the BHEX very easily. And this is a pretty hard cataract, so if you had any doubts as to how large a pupil you need, 5.5 I think is more than adequate. So if we could move further, yeah. And it's good for all stages of nucleus disassembly and IOL implantation. One good tip in small people is you keep the anterior chamber underfilled with viscoelastic, allow iris bowing, and so that it helps in hooking the iris if you're using iris hooks or placing the flanges or any part of the pupil expander. Overfilling the anterior chamber actually is counterproductive. You're flattening the iris against the lens capsule, and that leaves no room for the device. Now, for the BHEX works very easily for any any incision 1.8 and above, so you can easily put the device inside. Like I just showed, I injected viscoelastic under the pupil margin, and it's a very thin device, and you can tuck the flanges, alternate flanges under the pupil margin, and you have a very helpful 5.5 millimeter pupil for all your surgery. This can, practically allows you free surgery at every stage, including IOL implantation. And removal of the device is very easy. Just hold one of the flanges, advance it centrally, disengage the two notches on either side, and just drag it out, and it comes out. Now, if you want to inside the device through a 1.2 millimeter incision, you could do that as well. Just a little change in technique. If the flange is lying across the incision, it is difficult to put it in. It's a 1.2 is a very small incision. But if you hold the flange, like I said, if you hold it in the middle, it will not go in so easily. But if you hold the flange at its end, so that it's aligned more to the incision, it just goes through. And you can put it in even through a 1.2 millimeter incision. No device in the history, no pupil expander in the history of ophthalmology has been able to do it so far. Now, removing the BHEX. You could remove it through even a 0.9 side port incision. It's as thin as a human hair. So there you just grab the flange over there, the corner, advance it centrally, disengage the two notches on either side, and just drag that device out, and it comes out very easily without any resistance. Now, a few words about iris hooks. I'm sorry, this is a very old video. I do the side posts first. I do not overfill, like I said. Now, I like to keep the parasite a little clear corneally and posterior directed, and I like to also make marks in the conjunctiva, small nicks over there, because sometimes it gets very embarrassing, you can't find those incisions. Now, retract that stopper well in advance, and because that can get embarrassing if you're not retracted the stopper, and then hook, and do not stretch it all the way. Just do a partial stretch, and I do the phacoincision. And do not get carried away. This is a very large pupil. This is very old. This is actually taken from a VHS cassette. I have not used iris hooks in a very long time. And must remember that the pupil margin is antiflexed. The pupil margin is at the limbal plane. So any instrument which goes in is going to push the iris. So be very mindful of that. While removing, just hold the stopper, advance the hook a little into the cut, and just pull it out. The hook just straightens momentarily and walks out of the incision. It's a very easy thing. No highly skilled techniques required. Now, there are certain concerns with iris hooks. There are multiple incisions. The risk of infection, at least theoretically, exists. Iris sphincter damage is there. The corner space is wasted in iris hooks. So that's actually a shame. And like I said, the pupil margin is elevated to the limbal plane. So that, again, comes in the way of your devices. And, of course, there is a publication which does say that iris hooks take longer than pupil expansion devices. And if you had a bad IFIS case, you would have marks like this at the end of the surgery, up in the post-op period. So for a device in IFIS, we require something which goes through small incisions, has a low vertical profile, can exit through the side port. So iris hooks and BHEX pupil expander both fit the bill very well. Now, when it comes to intraoperative meiosis, now the BHEX again serves the purpose very well. With the Malugin ring or other pupil expanders, you really can't see the gap on the side which engages the pupil margin, so you never know when you're catching the capsular excess margin. But with the BHEX, what you can do is you can just inject a little viscoelastic in front of the capsular rim, and as you tuck those flanges, you can push it to the periphery, and you have instant confirmation that you have not engaged the capsular excess margin. If you have, you can just withdraw a little and again go back. So you're doing that all on direct visibility. Can I have audio, please? Audio. So it's a privilege to have Dr.
This
David
ring is
Chang.
very popular in Asia, I believe, and in some European countries. And again, it's FDA approved, and he calls it the B-hex ring, and it's really, really thin. So this ring comes out really easy. It's flimsy, it's thin, and we pull it right out.
Now, this is also available on the AO website. This was a wonderful case by Dr. Michael Henry and Deepak Edward, where the BX was used in a pre-existing tube shunt, and a single incision was used, and look how the flanges are maneuvered around the tube shunt. There it is, the flange is held, and it's going around the tube shunt and tucking under the pupil margin. So this is a wonderful, it's available on the AO website even now, and that facilitated the phacosurgery very much. So now, choice of pupil expander. When I have intraopmyosis, I would recommend iris hooks or the BX because they serve the purpose very well. If I have a subluxated cataract, there is no second thought about it. I would use iris hooks only because you can, use it segmentally. I can expand the pupil wherever I want. Clock hour wise, I can control it. I would strongly encourage you to look at this PDF, which has got video links. This is very informative. Thank you very much once again, Dr. Mohanta, for this opportunity. And this is also available on eophthal.com, very easy, freely available. Thank you very much.
On announcement, please, those doctors who have come later, you can write your names in such papers, and we'll have a lucky draw at the end of this session, and the winner will get a pre-chopper and a sustainer.
Can I take some questions before I
Yes.
if there are any questions, I'll be happy to take them because I'll be running off to another hall. I've got 2 more ICs to do in this session. So if there are any questions, I'll be, or else you always have me around. I'm just a phone call away.
One question is, can we apply BHEX in topical cases without giving block? What's the experience of the patients?
I have never used a block for a BHEX. I have not used a block in ages.
Do the patients feel pain?
No. See, the popular misconception we have been taught actually from our undergrad, from our post-graduation days was, if you handle the iris, there will be pain. Yes, if you hold the iris while doing a PI, peripheral iridotomy, if you grab the iris with the forceps, it causes pain. If you stretch the pupil margin, actually it's more stretching of the anterior chamber which causes pain, but tucking of the flanges or for an iris hook or even BX, there is never any pain, never.
Yes, if I can add, I do all my cases under topical anesthesia, and you can use the intracameral like Phenoken Plus if you want, but blocks are not needed. The one advantage of BX over the iris hook, I feel, there are quite a few. One is the aesthetic. The pupils after the operation postoperatively is round, whereas in iris hook you are stretching the pupil and they looks quite irregular if you are using iris hook. Second thing I have felt using BHEX is the postoperative, not only the postoperative thing, is with iris hook you are pulling the iris, as Dr. Bhattacharya says, superiorly. So while you are inserting the phaco tip, there is always the chance of injuring the iris. Just last week, I was called to the next door OT where the junior surgeon couldn't insert the phaco tip because he was pulling the iris hook quite a lot. So in those situations, if you face those situations, the ideal thing is to loosen the superior to iris hook slightly. The iris will fall down, and put visco over the iris plane and go in. But this problem you will not have if you use BX forceps, BX ring. And ideally, there are people who have complained that we couldn't insert the BX ring properly. I would suggest to use BX forceps instead of using dialer. BX forceps you can use from the main port, as Dr. Bhattacharya said, you can use from the side port to put the flanges under the thing. And the greatest advantage is when the pupil comes down during operation, after the rhexis is being done, BX is the safest option, putting pupil expander when the rhexis is done. Because what you can do, you can put it under direct visibility. You hold the BX with the with the BX forceps, push the iris slightly, tuck it up slightly, and go past the rhexis margin and then leave it. So there is no chance of catching the rhexis and extending the rhexis with the BX ring.
Thank you.
If
Thank
that
you,
is
Shraddha.
an-
Yes, that's, I think, pretty
One
comprehensive.
more point, Dr. Soben. One patient, there was IFACE as well as LIDRS at the same time. So people became small. I applied the BHEX, and immediately I go with irrigation, people dilates, and the BHEX comes in the anterior chamber.
Yeah.
How to overcome
So
such?
let's just deal with a situation where the pupil dilates after you applied a BX. Simple, just stroke the iris with the second instrument and induce meiosis.
Okay.
So stroke the iris and induce meiosis. Okay, so that will hold because, and of course you have to take care of your flow parameters because if your pupil is dilating so much because of the fluid that is coming in, that means your flow, and actually you probably could have got away without a device, but could be an IFAS case. So,
Yes.
so the ideal is just stroke the iris, induce a prostaglandin release. You're inducing prostaglandin release, which will cause meiosis. So once it's meiosis, the ring is firmly anchored.
Thank you.
Yeah.
So we have to excuse Soben
Yeah.
because he has another
One
session.
more point I would like to add, taking out of the VX, lot of us, we feel we are comfortable putting the IOL, implanting the IOL under irrigation. So if you are putting the IOL under irrigation, you can still take the BX out very easily under irrigation. Just keep the irrigation on. After implanting the IOL, just take the BX forceps and dislodge the BX and take it out. One tip is don't let go of the BX because if you are taking it out under irrigation, what happens is very light device. If you let go of the BX, it will just go around and float around. So keep hold of the BX with the BX expander, just pull it centrally, dislodge it, and pull it out at the same go. And so that eliminates putting visco for implanting the lens and taking out the visco after taking the expander out. So you can easily do it under irrigation.
Thank you, Sugata. I think that you covered those points so beautifully. Yes, for those who use hydroimplantation, it's a very useful tip.
And during implantation of the intraocular lens, do we have to enlarge the main wound so that the tip of the cartridge goes beyond the main wound margin? It goes the flange, beyond the flange. Do we have to do that?
I have checked that. I have left the haptic on the iris, pushed it against the BX. It is absolutely stable. It doesn't get disturbed.
So the question over here is, if you have a partially delivered IOL, and how do you deal with it? Now, that's a little tricky over here. If you're using a hydrophobic IOL, the unfolding is very slow. So you can take the trailing haptic very easily into the bag. Let's say your trailing haptic is already opened up and the flange is there and the IOL is above it, the trailing haptic. So the trick over here is not to think like we do when we don't have a device. We push the IOL back posteriorly onto the pupil margin and then get into the bag. That is something we should avoid doing because then you will take the BX into the bag. So the idea is to push the haptic in the same plane so that the leading haptic flexes against the optic at the equator of the bag, and now your trailing haptic has enough room to negotiate the BX and go into the bag. So you do not push it posteriorly, you push it in the same direction, and then once it's cleared the pupil margin, and then you tuck it into the bag. Thank you very much, and I'd like to be excused. Thank you very much.
So, thank you very much. Please be active, interactive, and ask questions so that we get encouraged. Now, I'll present a case with 3 to 4 clock hours of zonular dehiscence, and it was the right eye of the patient, and the zonular dehiscence was from 8 o'clock to 11 o'clock. Okay, यहाँ से करना है क्या? I'll do this. is coming. Yeah, slide show nahi. I have to forward this slide show je na. No. Slide show. Let me check. Yeah. So in this case, what I did is I used my non-dominant hand to manage the case. It's very important that we train our non-dominant hand. That is, if you are a right-handed person, you train your left hand. If you are a left-handed person, train your right hand so that you can manage difficult situations. This man is my inspiration to train my left hand. This man was born in 1910, Carolita Cox. At the age of 28, in 1938, he lost his right hand. He was in Hungarian army. While in practicing session, a hand grenade burst into his right hand, and it just blew his fingers. He was in hospital for 1 month, and then he cried. All relatives came and tried to console him. He got angry, and then he thought, how can I fulfill my dream of becoming an Olympic champion? He pondered, and found that I have my left hand, and let me try if I can train my left hand for pistol shooting. He went to a jungle and practiced for 1 year. In 1939, in Hungarian annual athletic championship, he went, and everybody was very happy that somebody has come to watch us. He said, no, I have come to compete with you. And he used his left hand, defeated all of them, and became champion. In 1940, he could not participate because the Olympics was cancelled. 1944 was also cancelled because of World War II. But in 1948 at London, he participated at the age of 38 and became world champion in a rapid-fire pistol event, and it was his non-dominant left hand. In 1952 also, he got another gold medal. So let us now watch this video. All of us can take inspiration from this person and train our left hand.
Surgery with the non-dominant hand.
So this is the video. This is from 8 o'clock to 11 o'clock. There is zonular dehiscence, and we have to do this case. And this is the right eye. So here I use my left hand to make the incision at around 2 o'clock. The side port is made at around 10:30, at around 11:30. Air bubble is placed. The anticapsule is stained, and capsulorhexis is done. I made a flap with the right hand. Now I am using my non-dominant left hand to complete the rhexis. Yes, it becomes slow with non-dominant hand unless you practice it many, many times. Sorry. And now, after hydrodissection, I'm going to put a CTR. For this, I made another side port at around 4 o'clock. The CTR goes, the leading end should go under the rhexis margin, and the CTR should be placed, you should introduce the CTR 180 degree away of the zonular dehiscence. Suppose the zonular dehiscence is at 6 o'clock, you should introduce the CTR from 12 o'clock. If you introduce other way, the zonular tear can increase. And now see how I place the CTR in the bag. The trailing end is placed in the bag with the help of a Sinskey hook. And now I used a pre-chopper to divide the nucleus into pieces. Because zonule is very weak, the irrigation fluid pressure can cause tear of more zonular fibers. So I just wanted to pre-chop this nucleus into some pieces. At that time, I didn't design my own pre-chopper. This is Dr. Sohail's pre-chopper. This is an old video of about 2 years. And now the handpiece is in the non-dominant left hand. The chopper is in the dominant right hand, and I start emulsifying. The dominant hand still does more and separates the pieces, and we could emulsify the pieces. Now let's just forward this. During emulsification of the last portion, we have to use visco to push the posterior capsule down, some visco in front of the lens matter, and emulsify the last portion of the lens matter, epinucleus mainly in this case. In this case, there was hardly any cortex left. So I inject visco and place a lens in the capsular bag. In this case, I used my right hand to push the lens. So it's a combination of right hand and left hand to avoid the area of zonular dehiscence. After aspirating the visco, one thing we must do is check if there is any vitreous strand anywhere in the anterior chamber. I found that luckily in this case, no vitreous prolapse occurred. So we completed the case nicely. The postoperative outcome was excellent. There's a quote by Mr. Jim Rohn, wish not it were easier, wish you were better. Don't wish for less problems, wish for more skills. Don't wish for less challenges, wish for more wisdom. Thank you. Now I invite, okay, any questions, please? Any discussion about this case, you can ask. Dr. Sugato, any inputs?
For the beginners who are doing phacos with zonular dehiscence, it is always better to, before starting anything, put diluted triamcinolone to see if there is any vitreous already in the AC from the zonular dehiscence area. If there is, you can do a little bit of vitrectomy there before staining the capsule or before doing the capsulorhexis. The other option you can do, if there is just protrusion of the vitreous, what you can do, you can put viscoat or any similar Indian available things to push the vitreous away and then stain the capsule, if you're staining the capsule. Other advantage of using the viscoat for pushing the vitreous away is that prevents the dye, because if you are not careful, the dye can go behind the nucleus, behind the cataract, and can stain the vitreous and can make the phacoemulsification difficult. So put a little bit of viscoat in the area of the dehiscence first, then stain the capsule, and then go ahead with your surgery, as Dr. Mohanta has said.
Dr. Subroto, do you use CTRs routinely in your cases?
Microphone. Sorry, you asked me or?
No. Okay, you can answer for your cases.
Only if it's required, yes. Not in routine cases, but there are surgeons there are several theories. Like in high myopic patients, there are surgeons who routinely use CTS. Also in pseudoexfoliation cases, they routinely use CTS because the capsule contraction, anterior capsule phimosis is more in those cases, but I don't routinely.
Yes. Any question?
Good morning, sir. Prateek from Patna. Excellent case, sir, and I have been following these videos online as well, so there are a lot of learning points. As a novice surgeon, I was told once that you can use the non-dominant hand to keep the phaco probe in the center, and you can use your dominant hand to use your Sinski or the chopper to guide the pieces to your phaco tip.
Right.
Because as a novice surgeon, I tended to go to the periphery to grab the pieces using the phaco tip. So this is a common mistake that the beginners and the novice surgeons make. So it is a very good instructional video as well, and this can be applied to more circumstances than a zonal dehiscence alone.
Right.
So that's my comment. Sir, you have a large experience of training lefty as well as ambidextrous surgeons. What has been your experience? Can kindly share?
Repeat the question, please.
Sir, with lefty as well as ambidextrous surgeons, how is the tendency of going to the periphery and grabbing the pieces in the novice stage?
Yes,
Is there a difference?
Novice stage, it is more. As you become more experienced, you remain at the center. Novice people, it's a human tendency to go and grab. So go to the piece and grab it. But we have to remain at the center, bring the piece near your tip, and otherwise, see, in the periphery, the posterior capsule is very close to the tip. If you remain at the center, the posterior capsule is far behind. So we have to consciously train our mind to remain at the center and use our left hand to bring the piece near the tip.
So, sir, is it beneficial for the right-handed surgeons to use the left hand and not move it? Is it, does it help the tendency to not go to the periphery when you are using the non-dominant hand?
Non-dominant hand, it has a learning curve. Similar thing, you just have to find that where are you, and you should always tell yourself that I have to remain at the central part, not cross the central safe zone. It's like that.
So I think it's how you train yourself. Like I was trained by Dr. Simon Kelly in UK. So he was a lefty. So there you have a standardized training system. He was a lefty. So he used to do his phaco with left hand and left leg. He used to give an incision in that way. After completing his phaco, he used to let me, in the initial stage, do the IA in coaxial. So because the position of the incision was such, and because I was scared to change my position, and then they might think you're taking a lot of time and might not give case again, I started doing my IA with left hand and foot pedal control with left leg. Till now, I am doing my phaco with left leg, I am doing my IA with left hand, and nowadays, sitting on the top of the table, I am doing my phaco with my left hand as well. And you are right, when I'm doing my phaco with my left hand, actually, as Dr. Mohanta said, is the right hand is playing more important role because I'm keeping the tip in the center. and the right hand is doing the chopping. Without moving the left hand, the right hand is doing the chopping with the sharp chopper, and that way probably it's safer.
Exactly, sir. Thank you so much.
Dr. Shashank, any inputs, any comments?
Do you always put the CTR before the nucleus removal, or it is later on in any cases?
In this case, there is already a zonular dehiscence. So in this case, I just after hydrodissection, I applied the CTR.
When the point was using capsular support, devices, and then doing and putting at the end of the surgery, putting a CTR, because sometimes the cortex removal is difficult.
No, cortex removal is difficult, but if you are using CTR, you have to put the CTR most of the time before removing the cortex. Instead of pulling the cortex directly to the center, you hold the cortex, you move it sideways, and that loosens the cortex, and then bring it in the center, and then aspirate it.
And now, Dr. Sugatu, please start your
Sir, I have a question.
talk on phaco in posterior.
We'll take the question at the end because time, we have to keep in mind the time as well. So I think even for my talk, we'll take the question after Dr. Mohanto's talk. So I'll be talking about posterior polar cataract, steps which the beginner should master. So when we think about posterior polar cataract, the main thing come into our mind, how to manage the nucleus without getting a PCR, without dropping the nucleus. So we tend to forget the other aspect as well. Just look at this case, for instance. Hey, how do I play? Yeah, so look at this case. It's under topical anesthesia. I'm doing a side port, and keep looking. It's going in, and sudden movement of the eye, and the wound get extended. So, like in every cases, we have to keep in mind how you're constructing the wound, and more so in PPC. Because what happens now? The leakage from the side port will make the pupil smaller and smaller, and the operation becomes difficult. It's prolapsing everywhere. So, for the beginners, it's not just nuclear management. Every step has to be kept in mind. So, wound construction is very important. Next is CCC. So, CCC, what I do, normally for all my cases, I incise the anterior capsule with the keratome, as you have seen here. Only difference in PPC, I make it slightly smaller, because if there is a posterior capsule rupture, I can do the lens capture with the anterior capsular rim. So I tend to keep it at about 5 to 5.2 millimeter. I do use Haldipurkas or micro rhexis forceps, and go ahead and do the rhexis. So first step, I do the section, incise with the keratome the capsule, then do the rhexis. Now, second step is hydrodissection in any case. So hydrodissection is a big no-no for phacoemulsification in PPC. Sorry, what is happening? Sorry. So hydrodissection is a big no-no. You can do hydrodelineation, but not hydrodissection as a beginner. What you should do, because the cortex and the epicortex are adherent to the capsule, you can take a spatula. Array, what is happening? You can take a spatula, flat spatula, go under the anterior capsular rim, and with a swiping movement, you can separate the epicortex from the nucleus, because that gives you a cleavage later on. Or you can, what else you can do? You can take the cannula, like in the second case, and inject very little bit of fluid while doing mechanical separation, very little bit of fluid, so that it doesn't go behind to the posterior pole. So that is the other option you can do. Now, nucleus management, coming to nucleus management, I have a technique of my own, and everyone have a technique of their own while managing posterior polar cataract to make it safer. Now, for softer cataract, you can do hydrodelineation, and you can just engulf the small nucleus. But for harder cataract, we are not doing hydrodissection, so we are in the back foot. We cannot rotate the nucleus, because that can cause disruption of the posterior capsule, so we are in the back foot, so what can we do? So what I normally do without rotation, if you keep an eye, I have done the first chop. I've done the first chop here with a vertical thing. I'm tilting my phaco-tip slightly to get a pizza pie of the nucleus. So I have done the second chop and I take that out. So I have taken 1/4 of the nucleus without rotating the nucleus. Now what I'm doing, I'm further tilting the phaco-tip and burying it inside the nucleus. Look where I'm putting my chopper, not against the tip, but the side of the phaco-tip, and separating the nucleus. And now I'll emulsify that part. So half of the part is gone. What comes into mind at that stage? Now if I drop the nucleus down now, I'm dropping half of my nucleus. I have to pay half of my fees to my retinal colleague. So jokes apart, what I'm doing now just nudging the nucleus out from the thing without rotating and chopping it again and take the fourth piece out. So far I am not rotating the nucleus. By this time the nucleus, the natural flow of fluid has done the hydrodelineation quite well and the nucleus is mobile, and now I am able to take out the last piece as well. So without rotating the nucleus. Now for every beginners, don't take out, half the job is done. Don't take out your phaco-tip, put visco through the side port, fill in the visco so that the chamber doesn't collapse, and then take it out. Now you see, I had created a cleavage, so from that cleavage, I'm injecting visco behind the anterior capsule and separating the epicortex from the posterior capsule up to the polar cataract adhesion. So I'm in different places, I'm putting visco to leave that out. So my job has become easier because I had made a cleavage in the beginning. And once that is done, you see in my second instrument is not a chopper or dialer anymore, is the viscoelastic cannula, so that I can fill it in whenever required. And I just take out the loosened epicortex and fill in with the viscoelastic. And then I go ahead and complete my phacoemulsification. So that is a point to remember. Don't take out your phaco-tip at all without filling it. Here is another case. It's a small PPC. I'll just move forward. All my cases are done under topical anesthesia, and patient's cooperation is very important. So this was the case. So I'll just, after taking out the anterior epicortex, against the same technique, slightly to the side, bury the nucleus, do the first chop, tilt the phaco-tip, do the second chop, because these are harder cataract. So do the second chop and take the pizza pie out. That will give more space for you to manipulate. So the first piece is taken out. Now I will tilt my phaco-tip again, and this portion I have to take out. So again I'm doing the chop. The first chop fell, don't get disheartened, re-engage it, and do the chop, separate the nucleus, and take it out. Now for the remaining portion, as I've said, by this time there is a lot of fluid flow, so the nucleus can be very mobile. So I'm taking the third piece out. With the, if you have noticed, the chopping was slightly different. It's in opposite direction, and now there is some epicortex and the fourth piece, which I have just slightly moved the nucleus and take it out. So the take home is, don't manipulate or move your nucleus too much. You can do the phaco successfully even without rotating in nucleus, which is quite important in posterior polar cataract because it can open up the PC. Now, coming to nucleus, coming to IA, again, if the pupil becomes small, you can use BHEX. You can, this is an old video. This is to show how foolish I was at that time. You can use your iris, you can second hand to move the iris away and do the epicortex cleaning and the cortical cleaning. The idea of showing this video that never polish a PPC. It will open up the PC. So at that time, I was not that experienced. There is a small piece of posterior polar opacity. I'm trying to polish that, and that's open the PC up. So never do that. You can yuck them later on. So I was lucky, it didn't open up too much. So I managed to put visco in, put the vitreous back and prevent it in prolapsing, and put the lens in. So the take-home message, not to polish the capsule. And if the PC opens up, you have to be well equipped, or you can take help of your seniors to manage the condition. So here you can see the PC has opened up vertical. There is no chance of doing PCCC. Be slow in taking out all the epicortex which is there. If the vitreous prolapse, you have to manage it. So here in the last moment, the vitreous prolapse, Here the last moment, the vitreous prolapse, if it prolapse, again, you know how to manage a vitreous prolapse with PCC, with posterior capsule rupture. Use all the armatorium. Triamcinolone to stain the vitreous, to do the vitrectomy, put the lens on the sulcus and do the capture of the IOL with the anterior capsular rim, and then complete your phaco using pilocarpine to make the pupil small. Sorry, where is? So here I am putting the lens in the sulcus. So for shortage of time, I'll just move forward. Dial the lens. So always put a visco between the iris and the anterior capsular rim, and after putting diluted triamcinolone, you can make out where the vitreous strands are. Do vitrectomy adequately to remove all the vitreous from the anterior chamber, and then use pilocarpine to see if there is any further picking of the pupil. Here the pupil is round, air bubble, and finish the case up. Thank you so much.
So this is the last presentation of this session. So, pre-chopper assisted phaco in soft cataracts. Now, why should we learn this? Why we are managing soft cataracts somehow? We should learn pre-chopping to manage special situations, but unless we practice this in routine cases, it will not be possible to use in special situations. If the zonule is weak, if there is zonular dehiscence, if the cataract is soft, grade 1 to grade 3, eye face, small people, this pre-chopper is a wonderful instrument. How does it differ from Akahoshi's pre-chopper? In Akahoshi's pre-chopper, the sustainer is not used in soft cataracts, but in my technique, I use sustainer in all cases. Lateral separation is limited in case of Akahoshi's pre-chopper. Here, lateral separation is as much as you want. It is in your hand. Learning curve in case of Akahoshi's pre-chopper, I thought it is steep, it takes longer time, but learning curve in this case, it is easy because all of us, most of us have done horizontal chop, the same kind of movement is there. You can think that the handpiece is the pre-chopper and the sustainer is the long chopper for horizontal chop. Akahoshi's pre-chopper is a costly instrument. It's about $1,000 US. if it is from proper Japanese company, but in this case it is economic. Now, steps to use Mohanta's pre-chopper. The sustainer goes through the side port first, then the pre-chopper goes through the main incision. The pre-chopper turns and its tip goes into the substance of the soft cataract, hooks the equator. Sustainer hooks the equator. The two instruments then come to each other, and lateral separation is carried out. Let us see this video.
And now see these steps. First,
The pre-chopper goes, then the sustainer goes, and now the pre-chopper is embedded into the nucleus substance, then the sustainer goes towards the opposite equator, 180 degree away. The sustainer hooks the opposite equator, then the two instruments are brought to each other, and we can divide the nucleus. Let us see the video. First the sustainer goes, then the pre-chopper is embedded into the substance of the nucleus. The sustainer hooks the opposite equator. The two instruments come to each other. We have to hook the opposite equator nicely and then do lateral separation. And now, let us skip this video. I'll show video clips in three situations. One is grade 1 nuclear sclerosis, grade 2, and grade 3. I'll forward the initial steps. And now the pre-chopper goes. This is soft cataract, grade 1, posterior subcapsular cataract. We can divide the nucleus easily in soft cataracts. In hard cataracts, the nuclear mass tends to rotate, but in soft cataracts, it will not be so. Now, after dividing the nucleus into pieces, we go and just start eating up the nuclear pieces. No struggle at all. As if you have cut an idli into pieces, and now you are going in and started eating up. And now let us go to the next case. Okay, this was what we saw is grade 2. This is grade 1. Rhexis is done. Hydrodissection is done. The nucleus is not rotated much at this time. We can rotate easily by the pre-chopper and the sustainer. In this case, I divided the nucleus into 3 pieces. Just one heminucleus is divided into 2 pieces. Then I rotated the nucleus, spinned the nucleus several times. This causes easy removal of the cortex after emulsification of the pieces of the nucleus. Okay, now we go to nuclear sclerosis in grade 3. So this is a harder nucleus. This case can be done by direct chop, just to practice this pre-chopper. We can do such cases with this pre-chopper. It will cause less use of ultrasonic energy. Hydrodissection is done. And now the pre-chopper is embedded just in front of the rhexis margin. The sustainer hooks the opposite equator. At this time, the nucleus tends to rotate. We have to keep balance in your hand in such cases. If you feel that it is becoming dangerous, just practice in softer cataracts, grade 1 plus or grade 2. And now we just have to emulsify the nuclear pieces. So next I could not get a case on IFIS and small people. And next presentation somewhere I will get videos for IFIS and small people. Thank you very much. Now we will have a lucky draw. I will call a senior person. Shekhar Dachen. Ashun, ekটু এখানে আসুন. Dais আসুন. We'll have a lucky draw. We have got names who came early in this session. Dr. Shekharda is not competing in this lucky draw, so he can pick up one piece, and the participant of this session will get a pre-chopper and a sustainer as a gift.
So for the beginners who are using the pre-chopper, what happens, we tend to press on the lip and the visco comes out. So don't get disheartened, you can put visco in, but the easier way is to use sodium hyaluronate like Hyaluron or Hilon. That keeps the chamber well formed and you can do the pre-chopping quite easily. যে কোনো একটা pick up one piece from there. So you can read it out the. Shomor Sengupta. Shomor is not here, so we can pick up a next chip then.
Yes. So yes, left. So he doesn't get this. We'll have another draw. The participant has to be present here. Please come.
So you can join eye surgery worldwide, and there are loads of video on this pre-chopping, which makes the surgery shorter and less use of ultrasonic energy. For the beginners, soft cataract chopping is quite difficult. Again, with this pre-chopper, lives become easier. So we have to leave within a few seconds.
Any questions, please?
We have run out of time. We have to.
Okay.